Hi there. Welcome to ComplyPlus Presents. I'm joined, as usual, by Dr. Richard Dune, but in a slightly different format today. Richard is joining us from Dubai. Slightly different sort of way of doing things today. Hopefully the output will still be as good and as useful to you all. How are you doing, Richard?
Oh, great. But I guess it's the same as England. It's very hot here and very humid, but kind of expected at this time of the year. But I was looking forward to this session because, when you're traveling, sometimes you lose track of where you are, but it's good to always catch up on Friday and talk about what's been going on, things that we care about, just from a different location.
Yeah, excellent. Today is a bit of a continuation from our last episode, but today we're going to look at mandatory and statutory training for adult social care providers. So last week we looked at healthcare providers. Today we're looking at the other side of the spectrum. Really looking forward to getting into this theme and discussing all things mandatory and statutory training for you adult social care providers out there. So without further ado, let's get stuck into the session. And similar to what we did last week, Richard, I think it would just be useful to get stuck into the terminology and look at what the difference is between statutory and mandatory training.
Yeah, look, these are terms that are used interchangeably. And, people talk about statutory sometimes when they mean mandatory and vice versa. And sometimes it's used as a catch-all phrase to capture all the different kinds of training that happen in adult social care settings. So when we're talking about adult social care, we're talking about community-based care providers, domiciliary care agencies, delivering care in people's homes, care homes, residential and nursing homes. So when it comes to statutory training for adult social care, we're talking about the training that is required by law. For example, one of the most important laws in the adult social care setting is Health and Safety at Work Act 1974 and the various regulations that are attached to that. So you have to do health and safety training by law. And there are additional regulations, for example, for fire safety, things like infection prevention and control, they're covered under the Health and Safety at Work Act 1974 and the accompanying regulations. Mandatory training, on the other side, is what an organization deems to be necessary for them to be providing safe and efficient services. So the organization has to do its own needs analysis. So they look at the service users that they are supporting, what are the needs of those people, and what are the outcomes expected, and what do you need to deliver safe and effective care. So I always like to give an example of something like moving and handling. For example, if you look at level 1 outcomes for moving and handling, you are looking at objects. So it could be boxes, it could be any bit of equipment that is covered in level 1 outcomes. But when you're dealing with people, it's very different. Even the way you do risk assessments before you transfer someone from a bed to a wheelchair, for example, or using a hoist, is completely different kind of training. So one is just generic and the other one is very specific to how you deal with people. So in short, statutory is required by law and mandatory is deemed by the organization as the training that is needed for them to deliver safe and effective care.
Excellent. And both of those are linked with CQC regulations.
They are, because obviously the Care Quality Commission, they are the regulator of health and social care in England. And they have the mandate to register organizations which want to provide regulated services. You have to register with the Care Quality Commission. And there are certain requirements that they have through their regulations, specific regulations from the Care Quality Commission. Those regulations are linked with the different laws. For example, Health and Social Care Act 2008, so regulated activities, which the 2014 activities, it requires staff to give training and organizations to give training to their staff and be able to support them and supervise them. So that's Regulation 18 of the Care Quality Commission. We also have Regulation 12, which is about safe care and treatment, right? So everything that you do, whether you're dealing with medicines, whether you're doing assessments, you're discharging someone, you have to think about that. Is there going to be continuity of care? And have we done the necessary risk assessments? Do we know what medicines they're taking? And the different other considerations. Then you have Regulation 17, which is around good governance, and we're talking about people being fit and proper to run these sort of organizations. So whether it's nominated individuals, directors, or owners of the businesses, or it's registered managers, there's an expectation that there's going to be good care governance in other social care companies. So, when we talk about governance, we're not only talking about the corporate side of things, making sure that you're financially sound, making sure that you have systems, but actually you're looking at the systems that are needed to deliver safe and effective care and answering those CQC key questions as well. Then you have Regulation 19, which is around fit and proper persons. So again, all these are related to the various laws of the country and various regulations, and we need to make sure that people are trained properly, they have the right systems, and they can deliver safe, effective care. It's as simple as that, really.
Excellent. Thank you for that. Staying with the regulator then, and sort of pivoting to the new single assessment framework, which is obviously a relatively recent update in how the regulator are regulating providers, particularly in adult social care. How does training come into the picture now with the new framework in place?
I don't know if you can still call it new, Lois. It's been around for over a year now. But obviously, there've been a lot of challenges as far as the regulatory framework is concerned. And the single assessment framework was supposed to be accompanied by the new software from the Care Quality Commission, and it's faced a lot of issues. And we know that the regulator themselves have faced a lot of challenges to get to where we are. But the single assessment framework simplifies how things are done. And for adult social care companies, there's not many significant changes when you think about it. You're still expected to do the same things, but now the focus is on evidence. How do you evidence what you're doing? Because we are now talking about the territory of smart regulation, right? And organizations now, the onus is on them to ensure that they're doing what is expected, and they can also evidence that they're doing things correctly. So you're looking at the 5 key questions. These used to be called the key lines of inquiry, but now they're just called 5 key questions, and they are accompanied by the quality statements. So you still need to answer the questions to, so are you safe as an organization? Are you effective? Are you caring? Are you responsive? And are you well led? And there are different ways to evidence safety. For example, if we look at policies and procedures, it could be your safeguarding policies, so safeguarding people that you're supporting, and making sure that you have good systems in place. So the policies are linked with the training that you're providing. So when people do safeguarding adults training, for example, safeguarding children training, it's linked directly to the law. There are specific provisions under the CARE Act. We're looking at multi-agency working, so ensuring that people know their responsibilities, so the organizational and individual responsibility. And then when you look at even basic health and safety training and risk assessment, it's covered under safety, but effectiveness as well. Are people getting the results that they expect? Because whenever people come to a service, whether it's a care home, whether it's a domiciliary care agency, they're expecting certain outcomes. So it's about checking that we're meeting those outcomes as well. So training has to be linked to all these elements. And one of the elements where people are failing the most when it comes to the key questions with the Care Quality Commission are around safety and well-led. So goes back again to Regulation 12, which is safe care and treatment, and Regulation 17, which is around good governance. The moment you have problems in those areas, you're going to struggle to get a good rating with the Care Quality Commission. And also people are not going to be getting the care that they deserve. And so it's about ensuring that we have the right policies in place to ensure that we meet the regulations. But also whenever we provide training, we do our needs analysis properly. We find a good training provider who is accredited and they've got a good track record. And also, we need to satisfy ourselves that the learning materials are suited to the business. Then there have to be records as well. So we have to have a policy around training and development. What sort of training do people need to cover the statutory needs? What sort of training do people need to cover the mandatory needs so that we deliver those services safely and effectively? Then induction programs as well. We have to have records for induction programs and onboarding to specific roles. We need to know when people should be doing their refresher. So there's a lot of guidance now that is available. Previously, it used to be quite a challenge, but Skills for Care have now sort of risen to that challenge by giving guidance. And that guidance is only a starting point. It's about the organizations ensuring that people are competent. So even if people do training, but you don't do assessments to check for people's competences, then you could still be found wanting because theory is quite different to how training will be applied in practice. So learning and development also needs to be embedded into the supervision and appraisal processes within the organization. Otherwise, what you end up with is tick boxes where we do training on one side, put policies and procedures on the other side, then practice on the other side, and there's no linkage between these key components.
3 areas, yeah. I think that's probably the key takeaway with the single assessment framework, isn't it? Even since it was launched, as you say, over 12 months ago, getting that message out there that, it's on you, it's your onus now to prove that you're complying and evidence that compliance through that journey. And that's why some of the systems coming onto the market now and being embedded in some of these services are really important because how do you do this evidence? How do you prove you're complying? CQC aren't going to make, answer all those things for you or do it for you. I think that's a really good point. I'm moving away from tick boxing and just saying, here's the certificates. We've done this for the year. We're compliant. We're fine. So hopefully this smart regulation will improve things as well, even for service users.
But again, the key with smart regulation, Lewis, as well, is to understand that everything that you're doing, say you get a new software system, you get training approved, it's about improving practice and outcomes. So as an organization, as a registered manager or as the business owner, you should be able to show how training is improving practice. You should be able to show how training is improving outcomes. So even the feedback that you get from service users and their loved ones, it has to show that there's an improvement there. It's not enough to just tick boxes like we used to do. That's why the quality statements are so crucial, because as an organization, you should evidence that there's a link. So it forces organizations as well to evaluate the effectiveness of training. It has to lead to improved outcomes across the board.
Yeah, I think that's a really good point. And we'll end on that one there. So the next section we want to look at, again, similar format to the last episode we did, is we want to now go through the core topics in the sort of adult social care matrix for mandatory and statutory training. So let's have a look at what training all care staff have to complete.
So if you go back to the statutory requirements, you start with health and safety. So health and safety training, including risk assessments. And that way you're meeting not only the CQC requirements, but the broader Health and Safety Executive Guidance for Care Providers and the Health and Safety at Work Act itself. Alongside that, you need to think about fire safety, the regulatory order from 2005. A lot of organizations, then there's a requirement for, especially those that are managing the buildings like care homes, whether it's residential, it's supported living, or it's a nursing home. You are in control of the building, so there are specific requirements of you as somebody who is in charge of that building. Alongside that, you've got infection prevention and control, which has its own regulations, but it's linked again with health and safety elements. You've got manual handling for both people and objects, basic life support. Some organizations do it as first aid, whether they do it as first aid at work or emergency first aid at work. Again, it depends on the risk assessments. You've got medicines administration. So within care homes, nursing homes, you have nurses that actually administer the medicines and manage the medicines. But in domiciliary care settings and residential settings, it's care workers. So again, the risk assessments have to be really clear there. If you look at safe care and treatment regulation 12, that's where a lot of the failings come in. Nurses go to university to study. They do pharmacology and they write exams. And then they work under supervision of senior nurses. And even when they qualify, the first 3 to 6 months, they work under supervision before they can administer medicines by themselves. But a lot of care workers, some of whom are new to the sector, are coming in and starting to give medicines within a few days of doing some online training. So obviously safety there, goes out of the window. So you need to address that as an organization, depending on the services that you're providing and the people that you're supporting. Food safety is crucial. All of these subjects are still under health and safety when you think about it. So safe handling and preparation of food, also doing risk assessments. Can people swallow? What sort of diet do they need? So it's looking at food hygiene, you're looking at food safety, but also nutrition and hydration as a subject. So all these really crucial. Then on the softer subjects, you've got subjects like equality, diversity and inclusion. So the Equality Act is very clear on people's rights and their right to access services as well equitably. You've got safeguarding, which falls under the safety side as well, because you're looking at how organizations set up systems in place to ensure that people are not harmed or abused. So it's about safe recruitment systems. So when you're employing people, you need to not only check that they've got the right qualifications and experience, but you need to check whether they're deemed safe to work with vulnerable people. So if somebody's got a criminal record or a history of abuse, then that person may not be suited to work in this environment, unless obviously there are circumstances that extenuate in that sense. You've got other subjects like learning disability and autism awareness, mental health awareness. So it depends really, but the statutory subjects, you have to do them by law. Then the other subjects, you are now doing your own risk assessments and ensuring that you're meeting the laws set out, Health and Safety at Work Act, the Care Quality Commission regulations, Fire Safety Order 2005, some nice guidelines. Maybe when it comes to subjects like epilepsy, diabetes, you have to follow the guidelines. The Care Act 2014, when it comes to safeguarding, Resuscitation Council guidelines, Health and Safety Council, Health and Safety Executive guidelines for first aid as well. So all these subjects, you have to determine what people do at induction level, then what people do as far as being onboarded into the specific roles that they are doing, then the refresher settings as well, because some subjects you have to refresh them annually. Some subjects you do them once and that's it. And some subjects, perhaps you do them every 3 years. So again, the organization needs to list those subjects and then go and look at the risks that are presented in that setting and how those subjects are going to help to mitigate that risk, and the refresher periods as well. You don't necessarily have to follow what Skills for Care is recommending, because all they're doing is giving you guidelines. Okay. And the guideline is exactly what it is. It's a starting point. Then you have to determine what's needed for your organization to comply and ensure that the training is fit for purpose.
Yeah. So we're not looking at a one-size-fits-all approach. We're looking at, like you say, the staffing roles. We're looking at what's relevant for your setting. Like you say, the guidelines are there, but they don't need to be followed, to the letter, basically. Yeah. Exactly.
Guidelines are a good starting point. So again, I give the example of care homes. You've got nursing homes and residential homes. Nursing homes, people need all care. So they basically need support with activities of daily living. They can't make their own meals. Some of them need support feeding. Some of them can't even get out of bed unless somebody is helping them get out of bed. They need help with washing and dressing. All these things need to be done. And you have nurses there working who are doing the care planning. They're doing the risk assessments. They're handling the medicines and administering the medicines. When it comes to residential care settings, for example, you don't have nurses in those settings. You've got care workers. They have to be trained to a very good standard so that they can understand the risks within the environment in which they're working. I always give the example of epilepsy and diabetes medicines, because when you look at CQC reports, that's where a lot of failings are happening, where you've got people who have complex care needs. And then commissioners are commissioning services to companies that sometimes are struggling to deliver complex care services because they don't have the expertise that is needed. And training is very poor quality sometimes, or sometimes actually they get entry-level training and then they don't continue to learn about those subjects. Because even for me, I worked in the NHS as a nurse for nearly 10 years, right? And you've gone to university to study, you work under supervision, and you have to keep learning, and you have to keep doing training. I had to go back to university to do postgraduate training so that I can understand how to look after patients who have heart problems. Yeah, acute. They say somebody who's coming in with chest pain, they've got a heart attack. How do you look after them? Somebody who is known to have heart disease and they're now on long-term medicines like warfarin, antihypertensive medicines, so medicines to help control blood pressure, diabetes, because people don't tend to have just one problem. Especially when you look when they're supporting people that are over 65 years old, a lot of them have more than one problem. So they may have high blood pressure, they have high cholesterol, maybe they've got a clotting disorder, maybe they've got diabetes, or they've had a previous stroke, or they're at risk of stroke. So when you're doing your care planning, you need to think about all these things. When you're looking at the diet as well that people are having, you have to consider all these things, because if somebody is diabetic and diet is not controlled, you can end up with all sorts of problems where then it's not easy to manage their condition. So it has to be organization-based and role-specific as well, depending on the risks that are presented for that particular organization. We could run a care company in the same city or even on the same road, but we're looking at different problems. People have different needs, and we have to be very specific to our own needs to be effective.
Excellent. So on that point, we're obviously going to now look at role-specific or additional role-specific training for adult social care providers and the staff that work within those services. So what about role-specific training? You know, what is it? What do employers need to do? What do they need to consider? Let's give the listeners a bit of thought on that.
Yeah. So like I said in the previous conversation there, you could have two organizations in the same city, but they may be offering different services. They may both be domiciliary care companies, for example, but one is looking after supporting people perhaps that have, say, mental health problems, right? And another is supporting people that are over 65 with different problems, long-term conditions, for example. So you have to, starting point is, what services are we going to be offering, right? When you register with Care Quality Commission, what services are you going to be offering? Because you can't register for one part and then start offering completely different services. You are not actually allowed to do that. Legally. So that's a very good starting point. Once you know what services you're going to be providing, then you put policies and procedures in place to ensure that you've covered all the angles. You do all your risk assessments. So before you even recruit the first person, you have to have those systems in place. How are you going to manage the risks? Then when you hire people, what sort of people do you need to hire? So that depends on the contract requirements, because commissioners, in most cases, will tell you what sort of people you need to be hiring, depending on the services that you are providing. For example, if you're going to be providing services for complex care, you have to make sure that people do the necessary training. If it's epilepsy, for example, or if people are going to be fed through tubes and people are going to have stomach bags and catheters and things like that, then once you identify the contractual requirements, you then look at the needs of the people that you are going to be supporting. What are their needs? So when it comes to care settings, we look at very basic needs, actually. You and I, Louis, this morning, we got up. We knew that we were going to be turning up to present a podcast. We got ready and we came here, and we didn't need anybody to support us with getting out of bed. We didn't need anybody to help us brush our teeth, to have our breakfast. So this is where, and I always want to take it to really basic human needs, to say people need support, right, at every level. So think of somebody who has dementia, for example, right? Perhaps they can't even remember that they don't live in their own home anymore. They live in a care home. Somebody needs to remind them where they are. Somebody needs to remind them to eat. Somebody needs to make sure that they've eaten, make sure that they go to bed, make sure that they get up at the right time. All that is really important. How about somebody who is at the end of their life? Whatever condition, whether it's heart failure, whether it's cancer, or any condition that is life-limiting in that sense, right? They're now needing support to do things that they were able to do before. What if somebody has an accident and then they have traumatic head injury, and then they're paralyzed. They're lying in bed now 24/7. There are a lot of young people post-road traffic accidents now in their late teens, in their 20s, in their 30s that are paralyzed, and they need all care. One day you were fine, the next day you need complete care to do anything at all. What about people that have behavior problems, whether it's on the autism spectrum or mental health problems? What about digital skills? What digital skills do people need? If your care plans are electronic, do people have the skills to use an electronic system? Have you trained them on using it safely? What about the considerations for GDPR? If somebody is being fed with tubes or they're on a specific kind of diet, if people had the training to manage nutrition, different nutritional needs, what about mental capacity for somebody who cannot make decisions by themselves? They need people to make decisions in their best interest. Do people understand the law? Do people understand the limitations and their responsibilities? Another area that is coming up a lot in adult social care settings is poor oral health care. So people end up actually having teeth removed, or maybe they have dentures, but the dentures are not cleaned properly, or the dentures are not, nobody even knows where they are, and people are expected to be eating every day. We take it for granted day to day until one day you can't do it, and you now need people to provide person-centered care, right? But then they have no training or awareness of that. You can't just walk off the street and start providing care. Of course, if say my mother or my grandmother needed care, I would support them as a relative. But if I'm going to do that in a professional setting, I would need the necessary training and I would need good systems in place. And I should get a good induction to understand my responsibilities, to understand the needs of those people. I need continuing supervision. I need lifelong learning because things change, guidelines change, and if people don't do refresher training, you don't update your policies and procedures, then you're providing inadequate care. It's as simple as that. And that's why some organizations, they may be providing good care, and then they're rated good or even excellent. Then they relax. They continue to do what they're doing, and then they don't innovate. Then a year later, they are deemed to be providing inadequate care, and then people get a shock. And they think, no, you don't get a good rating and then think we are fine. You have to maintain that rating by continuing to give excellent person-centered care and adapting and learning. Even when you make a mistake, what are the lessons from there? What can you learn to ensure that it never happens again in your organization, and all staff know why we failed, what is the impact of that failure, and what are we going to do in the future to ensure that we don't have similar problems?
Yeah. No, I think that makes sense. And like you say, we're also bringing in things like Regulation 9, Regulation 11 as well, with some of the examples you've given there. So we've talked about the training people need to do from a mandatory and statutory level. We've also now talked about additional role-specific training. But from the training needs analysis side, how do providers plan all this out now and sort of come up with that implementation plan? I know we've done an actual separate podcast on this for listeners if they want to go and have a deeper dive into training needs analysis. But just as it's quite relevant to what we're doing now, how do providers go about this?
Training needs analysis is essentially your roadmap, right? Without it, you're just ticking boxes. And I always say this to people, and they hate that phrase, ticking boxes. But actually, when you say to them, okay, look, so how do you determine which training to do? We got a list. Who gave you that list? They probably found it on the internet or another organization. Maybe they have a friend who's running an organization and then they get given a list. But how have you customized it to your organization? Even Skills for Care, they have a list of the core subjects, but that's not an exhaustive list. Even Skills for Health, the core skills training framework for healthcare, it's not an exhaustive list. It's a starting point of the core subjects that you need to cover. Then you need to do a staff training needs analysis. So let's take a care home, for example. They will have people in management. So they have a registered manager. Maybe they have somebody responsible for compliance and admin, somebody who's dealing with suppliers, somebody who's dealing with service users, customers effectively, right? They have non-clinical staff, people that are working in the kitchen. They have their own regulations that they need to think about when they're handling food, preparing food, right? So many things to consider from a food safety perspective, from food hygiene perspective, cross-contamination. So what training do they need? What about people that are cleaning, right? They need to understand the basics of health and safety, but they need to go further. They need to understand about controlling substances that are harmful to health, right? They need to think about reporting injuries and diseases and dangerous occurrences. What if there's a spillage in one of the rooms, right? What do you do? What about risks for Legionella, for example? Do you have people checking the water systems, the plumbing systems, the flushing those systems out and making sure that they keep you up to date? What about people that are providing direct care? What training do they need? What do they need to be aware of? What is expected of them? What are the limits of their roles? So you look at the roles of the different people working in the organization, right? And what are the risks that are associated with those particular roles? Then you look at the needs of the service users. When people come into a care home, whether it's nursing or residential, why are they coming in there? Of course, they need support. Perhaps they cannot manage at home anymore, right? So they now need people to be helping them with their day-to-day activities of daily life. Then when you're recruiting people as well, what are the minimum requirements? If it's a nurse, for example, or a physiotherapist or a therapy assistant, do they need to have prior experience? But even if they have prior experience, what do you want them to know about organization, your own organization? What does good look like in your organization? Because even when people are experienced, they may bring bad habits from other organizations. You don't want those habits now to come into your organization and then get spread very quickly in your organization, because it only takes one or two people to change systems. And if they're confident about what they're doing, it could be wrong, but yet they'll do it with so much confidence that they think they're correct. So what does good look like in your organization, apart from the existing skills that people have? So as part of workforce planning, and it's really crucial to do training needs analysis. It links directly with good governance, Regulation 17 of the Care Quality Commission. It also links with Regulation 11 around consent. You know, it's very basic, whether it's a doctor, a nurse, a physiotherapist, a care worker, people should always consent. You should always seek consent, right? And sometimes consent needs to be in writing, but in most cases, it's just verbal. You know, it's civility, basic civility. People need to know about professional boundaries so that they don't cloud their judgment by, crossing over those boundaries. When in professional settings, there are expected ways of behaving. And we should make sure that we stick with the policies and procedures, and organizations are equipped fully. And the training needs analysis does help with all those things. Even where we don't have a specific policy and we end up having a serious incident, it's an opportunity to learn. And the Care Quality Commission actually, and commissioners, they are quite happy for you to show that you are learning, right, from incidents as well and mistakes.
Yeah, I think that's a good point. I don't think regulators want to go in and think that everything's perfect or everything looks perfect. I think sometimes that self-admission and seeing how you've improved or what you've put in place to prevent that happening again can actually go in your favour, even with some of the inspectors that we've been speaking to over the last few months. So when we look at the training needs analysis, the idea really is so that it can feed into appraisals and development plans for staff as well. Is that what we're saying here?
That is correct. Because we're not doing a needs analysis, you're looking at the needs of a group of workers, right? So it could be a group of senior care workers, for example. But each of them now, when you're doing their appraisals and personal development plans, you are now looking at specific individuals and how they are getting on their day-to-day, right? And where they need support. Because you could have 5 nurses, and each of them will have different needs as far as their personal development is concerned. So it's about bringing that into your individual appraisals as well, and ensuring that you're customizing it for people. Some people may have been working in that setting for 10 years, and for someone else, they may have worked somewhere else. They've got the skills that are transferable, but they've never worked in that particular setting. They're going to need a completely different approach to the others that are more experienced in that area.
Yeah. Okay. Excellent. So let's take a look at the competency and sort of the quality assurance side of things now. So one thing we touched on earlier was we were talking about sort of how training is linked with policy, procedures, how then you've also got competency there on the other side. But as we all know, with a lot of the training readily available out there now, training doesn't mean competence. And I think that's a key thing for a lot of our listeners, particularly people running adult social care services, to remember. Because as you know, a lot of the training available now is more like a comprehension task. You know, if you read enough of the information, you will get the questions right at the end and you will probably get a certificate.
Yeah, certificate alone is not enough. Because even for a lot of subjects, there's theory and there's the practice.
Exactly.
I used to do advanced life support as part of my NHS role. And back then, the Resuscitation Council would send you books. Once you are registered, they send you a booklet to read. And then you spend 3 to 4 weeks going through that book. And then you write an exam. And then where you come for the practicals now, where you go into different stations and you're being assessed for your competencies of dealing with different kinds of emergencies. And that's a very good example to show that, look, I may pass the exam 100% on the theory, but put me in a situation where I now have to deal with that particular problem in practice. Can I deal with it? You know, whether it's a safeguarding concern or it's somebody has had a cardiac arrest, can I actually manage that situation, right? So competencies are important. And when you look at traditionally, whether it's medicine, it's nursing, or it's care work, people used to do apprenticeships. So you work under a senior person who is experienced, and then they teach you. You go, yes, you need to know how the heart works and how does it link with the lungs, how does it link with the liver and the kidneys. Anatomy and physiology is important, pharmacology is important, but actually to do it in practice, you need somebody now to teach you how to do it, how to write good care plans, for example, how to draft a reflection as part of your appraisal, right? It's really crucial. And even practical observations, for example, if I'm going to do clinical observations, I may know what a normal blood pressure is, but actually, do I know how to check the blood pressure properly? Because somebody is rushed. They've just been to the toilet, for example, and they've come back, they're a bit out of breath. That's not the best time to be checking their clinical observations. You need them to relax. You don't want them stressed. You don't want them in pain. So there are a lot of things to consider from a practical perspective. And some of these things actually only come with practice. It's not enough to just do training. It's not enough to just have certificates. People need to be able to do the jobs that they've been certified for, right? So there are formal checks that need to be done. People knowing how to use equipment for moving and handling, they need to be signed off. You need to do that. People knowing how to manage to use an AED safely in cardiac emergencies, that needs to be signed off formally. Then there's some informal checks as well that can be done. For example, in team meetings, people can present in a team meeting. You ask them to present on a particular issue, whether it's positive or negative. People can do quizzes, for example, lunch and learn. We used to get these when I worked in the NHS. You get drug companies coming in and they bring a lot of sandwiches and drinks, and you all go and pile in and you listen up to some information about a new drug that the company is offering. They're talking about what to look out for. Maybe they're showing you how to use a new pump or something like that. You may not be signed off on that particular day, but you've done the theory bit. Then when that pump comes into practice, you now need to be signed off to be able to use it safely and properly. Fire drills as well. The annual risk assessment that is done with a fire safety consultant or the local fire brigade. Do people know how to do evacuations? You can't expect people to just learn theory and not do the practical of evacuating someone down the stairs in a real fire, right? Or if they don't learn how to use a fire extinguisher or a fire blanket if they're working in the kitchen, for example, you can't teach them theory and they look at the pictures or video and then you expect them to be able to put out a fire using a fire extinguisher safely. They might get injured, they might harm others, and they might even make things worse if they've not done it in practice. Medication, which is one of the biggest problems right now across the board, medicine errors, people underdosed, people overdosed. But there are some things that you need to follow specific guidelines. You need to be able to read a prescription properly to know what medicine you should give, because some medicines have similar names, right? They may sound the same or spelling might look similar, right? But also the dose as well is important. There's a huge difference between 500 micrograms and 500 milligrams, right? For example, and if somebody doesn't get the C in between, there've been huge errors. Dangerous drugs like heart drugs, epilepsy drugs, diabetes drugs, any drug really, if you take a huge dose or if you're underdosed, there's going to be all sorts of problems. So competencies are important. Theory is crucial as well. E-learning, I mean, we run a business that provides e-learning. It can only go so far. You need then to check that people can actually go and do what they need to do in practice. That's the onus is on the organization now to do that.
Yeah. And I think, like you say, the experience and being put in those scenarios is the only real way to demonstrate competency. It's not about how many certificates you've managed to rack up in the last 6 months or the training you did last night or whatever. So I think the key there is training's only the first step. Application is obviously what matters. That's going to determine your outcomes. And application in any sort of setting in health and social care is the key. That's the difference between success and failure most of the time, yeah.
Exactly. When we started talking about training needs analysis, we talked about the outcomes. Because if I go in to a care setting and I'm needing specific support, there are outcomes that I'm expecting. Maybe I'm expecting my life to be better because I'm struggling to manage by myself. But actually things don't change, or I'm actually in a worse off position now. What's the point? My outcomes are worsening rather than improving, right? And also, even when commissioners come in to assess services, we've had these situations where an organization is frantic now. They're calling you to send a trainer because they're expecting commissioners to come the following week. And you think, hang on, if I'm a commissioner, and I realized that maybe 25% of the training that you needed to do, you've done it in the past week or two. I can put 2 and 2 together to say, look, this organization is reactive. They're not planning things properly. They're not looking at these things in advance, right? They're ticking boxes. If I'm a CQC inspector, I can see from a mile the things that you are trying to sweep under the carpet. And that's what people need to understand, that people that are working in commissioning, people that are working as inspectors, they've been working in similar organizations, so they know all the tricks to the trade. You are better off being open and honest to say, look, we realized actually that 2 weeks ago we had not done this. So we've updated our policy, and this is the training that we have done so far. And this is what we're going to continue to do in the future to ensure that we don't miss this part. So it's really important for people to think about outcomes. You can't just look at short-term outcomes to win a contract. Then once you've won the contract, you go to your default where you're ticking boxes again. It's quite easy to see when organizations are doing that. Even when we have gone in, whether it's consulting work or whether it's to provide training or to do an audit, you can see from a mile where things are going wrong. And as long as organizations are open and honest and they're willing to learn, you can learn how to do these things properly and also maintain good standards rather than ticking boxes as a one-off to win a contract or to get past an inspection.
Well, I think it's a business sort of adage in a way, isn't it? You think you've almost made it or you've cracked it. Like you say, it happens in many businesses, but with an health and social care, like you say, you get that excellent rating from the regulator. Clients are coming through the door, money's rolling in, and like you say, people then start standing still or reverting back to what's easier or more convenient. And things move so fast in health and social care. Like you said earlier, if you're not being innovative, if you're not keeping an eye on regulations, even things that are coming up in the news, because every day there's something in the health and social care sector that can probably be applied to your business in one way or another, depending on your mindset. So I think that's a really good point you've added there, yeah.
I think one thing to look at it as well, we've worked with organizations, for example, that got an outstanding rating with the Care Quality Commission. And within 2 to 3 months, most of the top leadership are gone. They've gone to what they perceive to be greener pastures because they're very marketable, aren't they? The moment you get an outstanding rating, everybody wants you. And we have had to deal with the mess afterwards where the key people in the organization leave because they managed to get CQC outstanding rating. And there's no one to fill the gaps because they didn't have
in a way,
they took the knowledge with them. There's no, when you talk about knowledge management in a business, actually it's about saying, look, it's not just one person. We're not compliant because of the manager. We're not compliant because of the CEO. We're compliant because we're an organization that is doing this, this, and that, right? And we've seen that where the CEO goes or the registered manager goes, and then all of a sudden there are huge gaps that perhaps the organization had not even considered because there's no business continuity planning, proper continuity planning. There's no succession planning. There's poor knowledge management. I'm sure we can even do different podcasts on those three things separately, each individually rather, because we're seeing it more and more where organizations get good rating or excellent rating, outstanding rating, then they relax. Then one person leaves, and then everything falls. They all of a sudden they're needing improvement in every area or even inadequate in all areas. So yeah, it's an interesting point that you're making there. It has to be a mindset within a business to sort of say, look, why do we exist? Going back to the mission, the values, the vision of the organization as well, and then building an organization that is continually learning, and then that knowledge is retained in the business, even where you have staff turnover, because people come, people go. You can't always retain your key people, but even if they go and you have good systems, then you're not going to fall to the ground just because one person has left the business. Yeah, it's something that we need to talk about a lot more, actually.
Okay, so the last sort of point on this before we wrap up, it again goes back to the sort of theory of mandatory and statutory training and how it links to the wider outcomes of the organisation. But linking training to outcomes, what's the impact on that? What's the reality of it for providers listening out there? And why really does it all matter at the end of the day?
Yeah, when you look at the main subjects that are covered in statutory and mandatory training for adult social care organizations, they are designed actually to meet the CQC regulations. They're designed to also answer the key questions. Are you safe as an organization? Are you effective? Are you caring? Are you responsive? Are you well led? So everything is connected, because if staff are trained and staff are competent, they are confident in delivering their roles. They provide care that is safe. They're caring. Even their documentation. When you just read their care plans, you can see a caring organization from one that doesn't care, where they're just ticking boxes. Staff are also making better decisions, because if you're confident about what you're doing, then it's not difficult for you to make a decision, because you don't need to ask a manager or somebody else to give you the reassurance that you're going in the right direction. If you know how to use a hoist, right, you know the checks that you need to do before you use the hoist. You know that you need at least 2 people to use that hoist, because you've been trained and you're confident about that. You know what you need to document if you're looking at urine output, fluid balance, how much did the person drink, how much did they pass out in urine and others, right? And are they within the required parameters? Maybe the GP has asked you to monitor them very closely. People are confident about what they're doing. There are also fewer incidents, fewer complaints. And there's good reputation as well, because even when you go on Google reviews or Trustpilot, if it's a care company, a domiciliary care company or care home, you see that they've got good reviews. And then the ones that have negative reviews, you won't want to take your family members there. You won't want to receive care there. And trust me, some organizations actually, I've done this when we're providing training, where I say to people, would you be happy if your mother was in this care setting? Or if you needed care, would you come to this company?
Yeah.
And then you realize people won't want to come to that company because they do not believe that they're providing good care, right?
Yeah.
They won't recommend it to their loved ones. They won't want it for themselves. So if you don't want it for yourself, why should other people come there and receive care from your organization? You don't trust that organization yourself, right? So ultimately, it leads to better lives for people that we're supporting. CQC ratings are a bonus, right? They're merely coming in to check that we're doing what we promised to do, right? Yeah. It's not a badge of honor. It's just a confirmation that you're providing good or excellent services that you promised to provide everyone. And I've worked with organizations that are applying, they're doing their business case and they're applying to get on the CQC register. No one says to CQC, we're going to provide very poor care. We're going to cut corners. Nobody says that. Everybody says what they're going to do very well. So when the inspectors come in or commissioners come in, they're checking that your systems are working. They're checking that you're doing everything that you promised. And that should be the norm. Good CQC ratings should be the norm. And some organizations get outstanding, fantastic. But actually, the moment you drop below what is expected, then you're inadequate. You're requiring improvement or you're inadequate. It's as simple as that.
Yeah. No, I think that's that's a really good way to sort of wrap things up. So just for everyone listening out there, from a summary perspective, what are some of the final takeaways based on what we've discussed on mandatory and statutory training for adult social care providers today?
Yeah, let's start with the basics. Why do we exist as an organization? So I talked about the documents that people fill in when they are applying for a tender or they're registering with the Care Quality Commission. We talk about these fantastic missions, the visions, and the values. Are we living them actually as an organization? Do we have policies and procedures in place? Then we do our training matrix. So we look at all the people that are working in the organization. What are we expecting them to do? What are the needs of the service users in the organization? Then we make sure that our training matrix is up to date and we stick with it. And when things do change, we also update it. It's not written in stone, right? To say, look, once we've done a training matrix, that's it. You have to constantly review based on what's going on in the organization and ensure that everything is up to date. Then you need to also look at staff competencies. There are certain skills that you're expecting people to have before they join, maybe certificates that you're expecting them to have. Make sure that you get references, make sure that you audit those competencies as well. When people do their induction and onboarding, you may actually realize that although people have the certificates, they may not be able to do certain things. So you need to then provide that additional training. It's not just attendance to say we've done the training, no, or we've got the certificate. You have to audit actually that people do know what they're doing and they know what good looks like in your organization. Then update your policies and procedures. Make sure that the training approaches as well have been reviewed. So do people need face-to-face training? Do they need e-learning? Do they need a combination? What about supervision as well and appraisals? So it's not just a compliance task. Training and development is a driver of quality in adult social care settings. And where people are ticking boxes, it's quite easy to see that people are merely ticking boxes because it'll be quite different to practice.
To practice and outcomes, yeah. Excellent. Well, look, I think we've hopefully summarised in the last hour a lot of the key things regarding mandatory and statutory training in adult social care, and not just talked about, the subjects, what we need to do, where we can buy it from, but actually the wider picture and how all this links to becoming a successful organisation and getting those ratings that you need from CQC. So thanks a lot, Richard. As we were saying throughout the podcast, we do have some things that we can provide you, some free resources, some downloadable items through our ComplyPlus portal. You should see on the website, we've got things like training matrix templates. We've got a training needs analysis template. We've also recorded some interesting webinars on this area as well, in terms of how training can link with policy and outcomes. And we do have some more webinars coming up for the last part of the year. We're running one every month. And I believe for some of you guys who will be listening today, they'll be very, very relevant. So if you do have any feedback, as always, put something in the comments. This will be going out on various social platforms. Subscribe, let us know your thoughts, let us know if there's any topics you want us to discuss. And we'll look forward to seeing you all again next week. And obviously, Richard, thank you for taking time out of your schedule to join me this morning.
Fantastic. It's always good to sit down and talk about things that we care about, a sector that we've worked in for pretty much our whole lives. And, any questions at all, people should send them over. We're also active on LinkedIn, on Facebook, and X. We give a lot of resources apart from the e-learning, train the train, and other things that we do. We give a lot of resources, even templates for policies and procedures to give people a good starting point, and also how to do it yourself. So for me, actually, it's always about enabling people to go out there and do these things in their organizations without having to rely on external providers, external consultants. If you're a registered manager, if you're an owner of a business, you need to learn how to do some of these things yourself, but also how to evaluate, how to find good training providers, how to find good consultants out there. It's really crucial that people take time to understand how the sector works and also their responsibilities. It's not enough to just register an organization your higher managers, and then off you go. You need to really care, and you need to continue to get involved in how the business is working and do your own audits. If you don't know how to do that, you can go and learn these skills so that you're not relying on outsiders. We were talking earlier about knowledge management. It's really crucial to do that, and for us, actually, we do the same. Every time the government puts a new document out, or there are issues in the news, we look at them, and then we try to understand what the impact is for the sector, what the impact is for service users, what the impact is for people working in the sector. And people should do the same as well. You should always look out on what's going on and how it impacts your organization, because it's quite easy for things to pass you by because you're too busy to even breathe and look around you sometimes. So we try to do that, to simplify what's going on. So if you follow us on LinkedIn, if you follow us on Facebook, you'll notice that we're constantly updating things. We're all constantly looking at what's happening and explaining what it means, actually. And then it's up to you now to sort of say, look, how does it affect my sector? Do I need to talk to my commissioners? Do I need to talk to other providers in the region to try to understand how it's going to affect us?
Excellent. Thanks a lot, Richard. We'll be back next week with a slightly different topic that we'll be discussing. So until then, have a good week, and thanks for listening.
Fantastic. Thank you, Les.